Hello, my name is Daisy Ortega, and I'm the Director of Training and Capacity Building here at Health Resources in Action. We appreciate you watching today's webinar, which is presented in partnership with the UMass Worcester Prevention Research Center. I'm now going to turn it over to Karen Valentine Goins, who's going to review a tool and having you to think about how to include or build in more physically active communities. So I will turn it over to Karen and she'll take it away.
Thanks, Daisy, and welcome to everyone viewing this webinar. My name is Karen Valentine Goins, and I'm a program director at the University of Massachusetts Medical School in Worcester, Mass, and part of our Prevention Research Center. The purpose of this presentation is to introduce you to a tool that public health stakeholders can use in their strategic planning to increase community physical activity opportunity. To set the stage, I just want to give you a little bit of information about my background. For 20 years, I've worked on physical activity and health, specifically active transportation, and my experience includes local public health practice, research, and advocacy. And I like to say that I work at two intersections between research and practice and between public health and transportation. There are three objectives for today's presentation. We're going to review the rationale, give you an overview of the rationale behind the work that I'm presenting today. Second objective is to explain development of a tool that we produced with input from a panel of over 50 practitioners in land use planning, transportation, health, and other disciplines, and explore its structure. And the last objective is to provide examples of use based on real-world situations. I want to acknowledge our collaborators on this work who represent a range of organizations from academic institutions to capacity building organizations to the membership organizations for Organization for Local Health Departments. And the work I'll describe today has been funded through the Physical Activity Policy Research Network Plus, which is a mechanism of the Centers for Disease Control and Prevention. I'm not going to cover this in any depth because many viewers are likely familiar with the statistics, but only 1 in 5 US adults meets the recommendation of at least 150 minutes of moderate intensity physical activity per week. And physical activity is responsible for substantial illness, deaths, and financial costs in the US and around the world. Research evidence has shown that active transportation, so walking and biking, can contribute significantly to overall physical activity. And this means it really should be part of the portfolio of any agency or organization that wants to increase physical activity. Decisions about community design are made primarily at the local level, although they reflect state law and national decisions and funding as well. And public health sector has traditionally not been involved with community design. It's not part of our training or typical responsibilities, and most departments are dealing with progressively fewer resources. Over the past 10 to 20 years, research has increasingly demonstrated the types of environments that are correlated or associated with higher rates of walking and biking. And there have been increasing calls for the public health sector to get involved. So one example is the Surgeon General's call to action to promote walking and walkable communities that was released in 2015. And this infographic and other materials are available from the website shown on the slide. It's not completely clear, but down on the right, you can see the public health sector there. Just want to note that public health is not limited to health departments. Other stakeholder groups include hospitals, community health centers, nonprofit and advocacy organizations. Other work that's been done includes recommendations based on the health impact of specific features of built environments. For example, the Community Guide recommends transportation and land use approaches in tandem based on a wealth of evidence. For example, I suspect most people watching this webinar have walked somewhere where the sidewalk ended before they reached their destination, or a crosswalk was available to cross somewhere along a roadway, but clearly not where people wanted or needed to cross. So these types of recommendations are very important, but continue to emphasize the what, sort of environments that promote more walking and biking, but don't really have the information on how. That is, what actions can public health stakeholders take to help push the communities they serve toward more active community environments. And in contrast to these recommendations, some of our earlier research has demonstrated low engagement by specifically local health departments on these issues. In a survey we conducted in 2012, we found that only about a quarter of local health departments reported participating in land use policy decision-making that would increase mixed use, density, street connectivity, or pedestrian and bicycle access. Somewhat higher, but still only about 40% of departments reported participating in transportation policy decision-making to increase pedestrian or bike safety or accommodation. And there were definite differences by size of population served, with officials of small and mid-sized communities less likely to report participating. And our subsequent work has focused on helping this group. So our ongoing research program, or our goal became to develop a tool through a rigorous research process with core capabilities, and I'll say more about that term in a little bit, for local health departments and other stakeholders to use in their regular strategic planning processes, so that they would be able to assess how their current activities fit into a physical activity built environment approach, strengthen their capacity over time by outlining options for next steps, and be something that is useful for departments and agencies that have varied level of resources and serve different types of communities. So we went about this by using a 3-round expert panel process to develop and then validate a tool that practitioners can use. And the next couple slides contain information about our development process. And we're including it to emphasize that we asked working professionals in these disciplines and not academics about what would be useful for public health, for how public health could participate. So our initial panel had 49 key informants, and we asked them, how can health departments help fellow municipal departments meet their own goals? What unique contribution can health departments make to local land use and transportation policy processes? What activities could health departments participate in that would have an impact on built environment decision-making? What knowledge, such as of laws, rules, and standards, would make them more credible? And what skills would help them engage in local land use and transportation policy process? And the focus of this webinar is on the activities that health departments can participate in that would have an impact on built environment decision-making. So we started out thinking about competencies as an end product, but competencies really describe the qualities that individuals would demonstrate. We found a useful exemplar in a guide that the CDC developed in 2011 using an expert panel process also to help local public health agencies build emergency preparedness competency. And we have a citation for that later, so you'd be able to check it out. So our qualitative analysis process from these interviews yielded 10 draft capabilities and associated tasks for each of those capabilities. We then asked the panel via an online survey to rate the importance of the capabilities and also rank them in 2 separate processes, first in terms of impact and then of feasibility. And to get more balance among the disciplines, we invited additional advocacy and administration panel members starting at this stage. The panel told us that all 10 capabilities were important, but there was more variation in terms of the feasibility. So given this and the tremendous fiscal constraints that health departments, especially local ones, operate under, it made sense to provide options for agencies with varying resources. So in our last step, we asked for the panel's agreement with our grouping into 3 tiers and each capability's assignment to one of those tiers. So this slide shows the final product, the cover of the guide, which can be downloaded from our website, which we'll link out to in a minute. And the third bullet there shows the exemplar that I mentioned earlier that we modeled the capabilities after. Before we do the link out, just to make the point that the capabilities are grouped into the 3 tiers, and then it uses color coding to differentiate them. Resource level is intended to be self-identified by the organization, and the guide provides some examples of resources to assess, including time and staffing. And it's important to note that the tiers are just a guide, and departments may find capabilities in each level that work for them. So now I'm going to show you how to link out, to access the capabilities. This is the UMass Worcester Prevention Research Center website. So you would navigate to the Research tab, to Current Research Projects, and select PAPRN Plus. Click on the Capabilities document cover. And it is a PDF, so I'm just going to scroll through it to give you an idea of what it looks like. It starts with a description of the background and purpose, and information on how to contact us, information about our development process, users, how to use, and then the next sheet is an overview of the capabilities in the tiers. Doesn't quite fit on one here, but this gives you an idea of what that would look like. And the subsequent pages are devoted to one capability per page, again, color-coded, and listing the specific tasks under that capability. So the listing out the capabilities, collaboration with other public officials, represent health and physical activity interests on land use or transportation policy boards, review and comment on plans, policies, and projects, plan and policy development, project development and design review, public outreach to community, policymaker education, data and assessment, dedicated staffing, and funding support. I'm going to go back to the presentation. So to reiterate, this guide is intended to be used by multiple stakeholders, health departments themselves, as well as hospitals, nonprofits, or advocacy organizations, and even public health training programs that are preparing leaders of the future. The ways that we see, several ways that we see to use the guide are, again, to assess current level of involvement for departments that have a history of working in this area, identifying additional capabilities that can help you meet your physical activity, active transportation goals, and selecting capabilities to pursue. Before we go to some examples, I just wanted to share a few results from a survey we did of local health departments in 2017 in collaboration with the National Association of County and City Health Officials. The survey was conducted to gauge their activities in terms of the topics that support active transportation, their capacity in terms of responsibility for the capabilities, and their interest in training and technical assistance with the capabilities. So as I said, we worked with NACCHO and got a representative sample from across the US in terms of geography and population size served. It was a web-based survey, and we did several reminders. We targeted the director, but they could delegate someone else to complete it. The topics listed there reflect what I mentioned a moment ago, and we got over 200 respondents who answered at least the items that had to do with up through the items that had to do with the capabilities. So a few highlights. Only half of the agencies responding said they have staff currently working on active transportation. And even roughly the same number, a little higher, reported their staff has received relevant training. And importantly, more reported bigger roles on what could be considered more familiar public health approaches, such as promotion, than engaging on systems change approaches, such as improving active transportation infrastructure or traffic safety and injury prevention, or land use strategies like smart growth and healthy community design. So most of the departments reported what could be termed community education or engagement as a major or secondary responsibility for staff or contractors. And this is really a more traditional public health responsibility. But each of the remaining capabilities was neither a major nor secondary responsibility for any staff or contractor. And the priorities for training and technical assistance that were expressed reflected that. They put a high premium on training related to that community education and engagement role. Moderate interest in collaboration, reviewing proposed plans or policies, serving on land use or transportation boards, policymaker education, and less interest regarding data and assessment, dedicated staffing, or funding support. In other words, assisting with grant writing for active transportation initiatives. So these data really told us there was room for increasing capacity and provided some guidance on where to start. So we want to provide examples of how local health departments and other public health stakeholders can use this tool in strategic planning. And the first example comes from my own experience in an older industrial city of about 200,000 people. Seen some hard times, but is experiencing a renaissance. And over the past 10 years, the health department has received funding from the state health department to work on obesity prevention, utilizing evidence-based policy systems and environmental change approaches, the what. And the health department has worked really hard during that time to build collaboration with the departments charged with the built environment, where no collaboration existed before. And as you can see from this timeline, there have been notable achievements in that intervening time based on this collaboration. So it can be helpful for this department to look at those achievements through the lens of the capabilities, mapping what they've worked on, and identifying new opportunities. So this table lays out the health department's current activities and potential opportunities according to the 10 capabilities. And you can see just with a quick look that they've done more in the first two tiers. So we're going to look at one capability from each tier in more detail, and I highlighted those in bold. Looking at the capability of representation on policy boards. In this community, the health department was able to gain permanent seats on the Metropolitan Planning Organization Advisory Committee. The MPOs are responsible for distributing transportation funding down at the local and regional level. They also have a seat on the Complete Streets Implementation Committee in the community. Some opportunities they haven't yet taken advantage of are, although there's been something of an invitation to join what's called the Interdepartmental Review Team that reviews designs for proposed development prior to the official process. And there's a design review committee that's actually developing now. In the second tier, I selected policymaker education. The health department was able to provide one complete streets training to elected officials. There's obviously opportunity to do more of those kinds of trainings, and also for some regular updates so that elected officials can become more familiar with the importance of built environment for physical activity and health. And actually those, and to share that information not only with elected officials, but staff and also board volunteers, meaning, for example, planning board or zoning board. And in the last tier for communities, typically listed for communities with the most resources, but they were actually able to, through some additional funding, do a health impact assessment. They also produced the first ever crash and injury report in the community. But there's still some real opportunity for compiling and sharing best practices from other communities. So for the second example, as part of our research, we collected publicly available community health improvement plans, or CHIPs, from communities that responded to our 2017 survey, where the health department said they were involved with the CHIP process. So this example shows an objective and strategies from an actual plan. And we've bolded one strategy, so again, we can look at it through the lens of the capabilities. And so the strategy, their objectives: implement planning, policy, and programs that encourage physical activity in our communities, work sites, and schools. And the strategy we'll look at more closely is seek to require that all new development includes safe routes to transit and regional and bicycle and pedestrian facilities, and incorporates recreational and open space for activity. So based on this strategy, we can see opportunities for the health department and other stakeholders to take actions that advance toward the requirement spelled out in the strategy. So looking at one from each tier, in the green, review and comment. Ideally, of course, they would actually be involved in the actual policy development, but if their collaboration with other officials hasn't reached that point, they might have an opportunity still to review a proposed regulation if they're unable to participate in its development. There's a big role in public outreach and educating residents about the implications of municipal decisions like these and best practices, and the benefits to the whole community of having a change that saying that all new development would include those safe routes. And assisting the community actually in engagement with the departments that are responsible for those decisions. And in the last tier, in terms of data and assessment, there could be a utility in compiling best practices from other communities, or if there were an opportunity that included funding, to do a health impact assessment of a new proposed regulation. So last, this is a quick example of how you could structure an action plan using the capability to help frame the tasks. Goal: increase community physical activity opportunity. Spelling out that the capability you're addressing is to collaborate with public officials. A SMART objective, saying within 2 years that the health department will be able to demonstrate that collaboration with those other fellow agencies that are responsible for the built environment, and measurable using the continuum of collaboration from only talk to the person once a year to regular interaction. And down the left, the tasks listed there correspond to the capability, and then the rest of it is a typical action plan structure with staff, time frame, measures, and documentation for it. So in summary, active transportation is a recommended approach to increase community physical activity. There exists an evidence-based tool to assist health departments and other stakeholders with cross-sector, that was developed with a cross-sector panel of practitioners, and that these stakeholders can use the tool to assess their current activities and identify opportunities and plan activities to align with health improvement plan objectives. So that concludes our presentation. Our next steps include continued dissemination of this as a standalone tool, as well as development of training and technical assistance mechanisms based on the knowledge and skills data that I mentioned earlier. This slide includes my contact information. I welcome questions or input as you integrate the capabilities into your work. And thank you very much.